afternoon and welcome to Specialized Epilepsy Centers and Providers, what patients and families should know. My name is Andrea Rassiopi and I'm Vice President of Epilepsy Services at Epilepsy Services of New Jersey and the Family Resource Network. I will be your moderator and webinar organizer for today's session. Before we start today's session, I just want to give you a little bit more information about our organization. Some programs I just want to highlight regarding epilepsy services that we have. Patient Assistance Program is a resource that we have that individuals can set up appointments with myself and my Spanish-speaking colleague, and we can discuss any non-medical needs. So for example, if your child needs help with their IEP, if you need some seizure recognition or response training for your workplace, we can really offer you these services. And if we aren't able to offer you services, we will find the places that do offer those services for you. So that is a QR code to set up an appointment. It is either Zoom or by a phone call. And you can also link to it on our website, epilepsyservicesnj.org. We have a health insurance navigator program. So if you need assistance in finding low cost or free health insurance, you can call one of our navigators at 1-800-355-0271. This is a listing of some of our upcoming events. We have our Day at the Beach. This is a beach day for people with epilepsy and their loved ones, a free event. Unfortunately, we're still waiting for a date for that, but that's not unusual. So look for an email about that or on our social media. Our handle is @EpilepsyNJ. Our 49th annual Golf Classic is July 14th, and that's Upper Montclair Golf Club in Clifton. Seize the Wave is a surfing event that we do in conjunction with Paul's Purple Warriors, and that's on July 22nd. It's for kids with epilepsy, and it's in CL City. Our Walk for the One is in Piscataway, and that's October 19th, and this is a walk specifically for people with epilepsy and their loved ones. We have a lot of great teams that are formed in recognition of an individual with epilepsy. And I know it's a ways off, but our Paint the Pony Purple is always in March, and obviously next year it's in March 2026, and that's in Asbury Park at the legendary Stone Pony. Here's just some of the information about our organization. As I mentioned, our handle is @EpilepsyNJ. Our website is epilepsyservicesnj.org, and our broader website is familyresourcenetwork.org. If you have any questions for myself or organization, our general email is info@epilepsynj.org. Before we begin, I just want to take a moment to make sure that you all are familiar with the technology that we're using today. Everyone has their own control panel in the upper right-hand corner of their screen. There's an orange arrow to open or hide your panel. To listen to the webinar, you have two audio options, either microphone and speakers or telephone. If you can't hear well using your computer speakers, you can elect to use your telephone to listen to today's session. In order to maintain the best sound quality possible, all but the presenter will be muted throughout the webinar. If you have any questions, please type them into the question section of your toolbar, and I will pose them to Dr. Alexieva at the end of the webinar. Okay, so we are going to get started. Second. Dr. Alexieva graduated from Emory with the highest honors for a thesis on protein binding in models of ALS and frontotemporal dementia, FTD. Much of her undergraduate work was spent volunteering in a dementia clinic and validating cognitive testing paradigms in populations with various levels of education. Before starting medical school, Dr. Alexieva was a programmer and analyst at Epic Systems, a medical records software company, for 2 years, working on ways to improve electronic medical record software to target better patient outcomes through meaningful use initiatives. She used this background to work on improving the electronic medical record to streamline care for epilepsy patients during her training at UCLA. She's always looking for ways to improve health record software. Her research interests include status epilepticus, traumatic brain injury, and post-traumatic epilepsy. She's currently with the Northeast Regional Epilepsy Group, and we're excited to have her on today's webinar. So welcome, Dr. Alexieva.
Hi, can you hear me?
Yes, I can hear you.
Okay, perfect. We'll go ahead and get started then. Let me just, can everyone see my title slide?
Yes, and it's in a PowerPoint mode. Yes, we're good.
Okay, perfect. You see the presenter mode, I'm assuming.
Yes, I'm sorry, and I was at a loss for words there. Yes, we're at the present. Yes.
Okay, excellent, excellent. All right, so I'm going to talk to you today about, and thank you for that introduction. I'll be focusing my talk on what are specialized epilepsy centers and epilepsy providers, with kind of a focus on what families and patients should know. So I've been, working in the epilepsy field now for a few years. I just recently moved here after I finished my training in California, so I'm excited to kind of bring my perspective from the West Coast and get to know the local epilepsy community out here. And so the talk today will be divided into two parts. The first part will be focused on the delivery of epilepsy care in the United States, what it looks like, what the different levels are. And then the second part of the talk will focus on what is an epileptologist, specifically what is the training path to that, and why is that training important? What distinction does it give us? So that you can be better informed in sort of understanding what background your providers have, who you might see in clinic. So starting with the delivery of epilepsy care in the US, what are the levels of epilepsy care? So this is a designation by the National Association of Epilepsy Centers, or NAEC, and basically level 1 care for epilepsy is considered at the level of the emergency room or the primary care doctor's office. Level 2 care would be a little bit more specialized at the general neurologist level, and then levels 3 and 4 are considered to be specialized epilepsy care. And so this is a diagram that kind of goes over what the flow of epilepsy care has traditionally been. This is from a guideline by the NAEC that was published many years ago in 2010. So I'll show you a little bit of an updated version, but basically what this diagram says is that a person who has a first-time seizure will usually go to the emergency room or see their primary care doctor, at which point, I think hopefully you can see my mouse pointer here, that they might, kind of remain controlled or managed by their primary care provider, assuming their seizures are controlled with some of the medications their PCP may prescribe. They might actually just remain managed by their PCP without ever seeing a neurologist. Alternatively, one might be referred right away to a neurologist or an epilepsy center, either right at the point of diagnosis or later on if seizures aren't controlled within a certain amount of time, or if there's a question about the diagnosis. And so, you might not get referred to an epilepsy center until at the very bottom of this diagram, where, you've been trying to control your seizures for a year and your neurologist has not achieved seizure control after 12 months. So this is kind of the old diagram, old way of thinking. Nowadays, especially with the greater availability of neurologists and specialized epilepsy centers, it's really felt necessary to refer right away to a neurologist after a first-time seizure. And I think most people invariably do get referred to a neurologist right away. But then the other kind of piece of this is that you don't really have to wait a year of failed seizure control to be referred to a specialized epilepsy center. A lot of people are referred right away to an epilepsy center even after their first diagnosis. And sometimes, now the recommendation is if 2 medications fail to control your seizures, you don't need to keep waiting and keep trying more medications. You should be referred to a center right away. And so we're going to talk a little bit more about what is exactly a specialized epilepsy center. These are also known as level 3 and level 4 centers. So a specialized epilepsy center is a program that not only provides routine care to individuals with seizures or epilepsy, but also specializes in providing comprehensive diagnostic and treatment services to individuals with uncontrolled seizures. To be accredited, centers have to meet a long list of specific criteria and guidelines, most of which are geared towards patient safety and quality of care. So they have to demonstrate that there's a multidisciplinary team with specialized training in epilepsy that can provide this higher level of comprehensive care. So it's a very kind of regimented process to become a level 3 or 4 epilepsy center with audits at every level. So here is a list of some of the resources available at epilepsy centers, and I'll just give a quick blurb about each one. So number 1 is consultation with fellowship trained epileptologists, and we'll talk in the second part of the talk more about what goes into that training and why it's useful to patients with epilepsy. Next is our epilepsy monitoring unit and epilepsy nurses. So many of you may have heard or been referred to an epilepsy monitoring unit. This is a specialized unit within hospitals where there's a dedicated team of technologists, physicians, nurses who work together to ensure that patients with epilepsy can have their seizures monitored and diagnosed appropriately. Again, this level of care is really not available outside the level 3 and 4 epilepsy center. And of course, epilepsy nurses are nurses who have greater experience in managing seizures and epilepsy and related conditions. The multidisciplinary team approach is a really large part of what makes an epilepsy center special and provide high quality care. So we've got epileptologists, neurosurgeons, neuroradiologists, epilepsy nurses, neuropsychologists, all these different people working together, not just kind of day-to-day in a patient care type of framework, but also in a very scheduled and deliberate way when we have our weekly or biweekly surgical epilepsy conferences where all of these specialists get together, and formally sit down or meet over Zoom to discuss cases in great detail for patients who are getting referred to epilepsy surgery. So this is a really great strength of epilepsy centers, is this multidisciplinary, collaborative, really formalized approach to patient care. Some epilepsy centers will have specialized pharmacy programs. So as some of you may know, epilepsy medications can be very difficult to get prior authorization for, get refills for, find pharmacies that have them in stock, be able to get controlled substances, especially if there's a change in address or some other kind of hiccup that require, if you have mail order delivery. There's all sorts of kind of complicated legal and logistical things that go into receiving your epilepsy medication. So some of these pharmacy programs can track patients, can give you a call when you're up for a refill or when your prescription's about to run out, and really just with the goal of making sure you never lose or run out of your epilepsy medications and prevent breakthrough seizures. Some epilepsy centers will have case management and social workers who can help, again, with some of the issues with disability insurance, getting, again, medications approved by insurance issues. So those can be really helpful, especially in the pediatric world with things like IEPs, day programs, and kind of getting resources for that. They can be really, really helpful. We have neuropsychologists, neuropsychiatrists at epilepsy centers. So these are individuals, doctorate level training who provide really detailed cognitive testing to try to map out some of the cognitive deficits that some of our patients have, whether it be attention problems, memory problems, problems with language. They can get a really detailed and specific assessment of what the deficits are and how to best treat them, ameliorate them. And sometimes it can be helpful diagnostically too, and can help point us to where seizures may be generated in the brain based on what the pattern of deficits is. Clinical trials we are often involved in, so that whether that's for medications, for surgeries, for new devices, epilepsy centers will be the place where you can enroll in and participate in those clinical trials. Pediatrics to adult transition programs. So as children age out of their pediatric epileptologists, they often will transition to an adult epileptologist, and often, pediatric and adult epileptologists work together under the same kind of umbrella at the epilepsy center, which can help make that transition a little bit smoother because it is very difficult for a lot of patients and families. And I talked about the multidisciplinary surgery conference already, so skipping on to genetic testing and counseling. This is another service that we provide at epilepsy centers, oftentimes, especially in pediatric populations. We can make a genetic diagnosis for different epilepsy syndromes, and that can be really helpful in terms of counseling and treatment selection. Dietitians and diet therapy are a very important aspect as well. So ketogenic diet is a very effective treatment for epilepsy, so it's a service that we offer. And then surgical treatment options too. I'll talk a little bit more about this in further slides, but there's many different surgical treatments for epilepsy when medications don't work, and epilepsy centers are really kind of concentrated areas where the experts in this type of surgery are concentrated. And so that's a big part of what we offer. And then, at the end of the day, this isn't a specific thing necessarily, but just familiarity with epilepsy patients and epilepsy care. We see epilepsy patients every single day. This is something we've been doing for years. A lot of us have been working in the field for many years, many decades even. So just having that familiarity with kind of what goes into the life of an epilepsy patient and how to best support them, I think is just a valuable resource in and of itself. And so what differentiates a level 4 center from a level 3 center? This is, a little bit kind of in the weeds, but in essence, level 4 centers must demonstrate that they have a higher volume of admissions to the epilepsy monitoring unit. So they have to have the capability for placement and monitoring of intracranial electrode studies. They have to have access to WADA testing and functional neuroimaging. So some of these kind of higher level, more subspecialized sets of testing, functional cortical mapping and cortical stimulation, access to PET or SPECT studies, whether that be in the center or referral out with a relationship with another center who can do those studies. Of course, resective or ablative epilepsy surgery has to be offered at a level 4 center, implantation of neuromodulatory devices. You also have to have multiple epileptologists, not just one, for a level 4 center, and a dedicated neurosurgeon. So again, level 4 criteria are really focused more on the surgical treatment of epilepsy and kind of demonstrating expertise and experience in that. So what are the indications for referral to an epilepsy center? At what point, what are the reasons to go there? Maybe you're seeing a general neurologist and you're wondering, do I need to go to one of these epilepsy centers? So I would say the most common indication for referral from general neurology to an epilepsy center is the failure of 2 or 3 medications to control seizures. Really, just failing 2 medicines is enough. And typically that means you have to have reached an adequate dose for at least 2 different medications for an adequate amount of time to assess seizure control. Once 2 medications fail, that's time, an indication to get referral to a center to make sure the diagnosis is correct and the medications are correct. And if those things are both true, then considering epilepsy surgery or at least discussing it. Other indications for referral would be maybe you have seizure control, you're not having seizures, but you're having intolerable side effects on the medications. So again, that's room for a discussion, selecting a different medication, and I'll have a slide coming up about kind of why that's important to do at an epilepsy center, discussing these different medications. Maybe the diagnosis is unclear. Maybe there's a lot of things that look like seizures that are not seizures, and sometimes making the accurate diagnosis is really what's needed for the patient. Another indication would be a desire for non-pharmacological treatment. So maybe if someone is interested in diet, surgery, neurostimulators, as opposed to taking medications every day. Management of epilepsy during pregnancy is another common reason for referral. So that's something we do a lot of. Enrollment in clinical trials, like I mentioned before. Sometimes just getting a second opinion. And people will go to more than one epilepsy center to get multiple opinions, which I think is always a good idea for a diagnosis as important and life-changing as epilepsy. And then nowadays, actually, we consider a first-time diagnosis of epilepsy to be a good enough reason for referral to an epilepsy center. So you don't have to wait until medications fail. Sometimes just getting that one-time consultation with an epileptologist just to kind of confirm what your neurologist is saying and make sure that you have an option, someone to see if the worst happens and the seizures become hard to control, you kind of have that in your back pocket. So here's a map of New Jersey with all of the level 3 and 4 centers. These include both pediatric and adult centers, and it's taken directly off of the NAEC website. So we're very fortunate in New Jersey to be not just close to New York City, where there's a really big concentration of centers, but also just having in general a large variety of centers to choose from, both within our state and in surrounding states. And I apologize, this says in New Jersey, but really it's showing in the surrounding areas. But either way, we're very lucky to have such an abundance of specialists here to get opinions from, second opinions from, and to really make sure that we're giving good care to our epilepsy patients. And then just a very brief word about the VA system. So Veterans Affairs, the VA system for military veterans, they have their own system called the Epilepsy Centers of Excellence, or ECOE system, which are a little bit different than the levels 3 and 4 epilepsy center, but it's a network of 17 sites that provide similarly comprehensive epilepsy care to veterans who served in active duty. And again, it's a nationwide consortium of the same types of providers and specialists that I mentioned before. A unique feature of these centers is that they're actually linked with polytrauma centers for traumatic brain injury patients and patients who are at risk of developing post-traumatic epilepsy. So they actually do a lot of work with post-traumatic epilepsy. And when I was a fellow, I actually did a lot of my epilepsy training at our VA in Los Angeles. And so I was involved in some research with post-traumatic epilepsy. So it's a very robust kind of program there, and they take really great care of the veterans through this network. And just here's a map showing where the VA ECOEs are. So, there's obviously not as many as there are level 3 and 4 epilepsy centers for the civilian population. And so next we can move on to part 2 of the talk, which is what is an epileptologist? I've been using that word a lot. And we'll start with basic definition. So an epileptologist is a neurologist who specializes in the diagnosis and management of epilepsy and seizure disorders, and typically is fellowship trained. So epileptologist training is a long road, 12 plus years after high school. And down here at the bottom of this slide, I have a little roadmap of what those years are. So we do 3 or 4 years of undergraduate training, 4 years of medical school. We do, this is for an adult fellow, but adult neurology residency is 4 years, and adult neurology epilepsy fellowship is 1 to 2 years. And let me see if I have a slide for pediatrics. I don't. So the pediatrics training is pretty similar to this, but their residency is actually 5 years, and it has an extra year built in of they have both adult neurology training, a full year, as well as their years of the pediatric residency and pediatric neurology residency. So it's a little bit longer a road to be a pediatric epileptologist, but their cross-training is required in both pediatric and adult epileptologists, meaning every adult epileptologist you see will have had required training in pediatric epilepsy and vice versa. So that actually makes it really, makes the transition from peds to adult a little bit easier, because both sets of doctors have that cross-training. In practice, as you may already know, adult epileptologists tend to only see adults, and pediatric epileptologists tend to only see pediatric patients, but technically we're board certified and able to see both, but in practice, it's just the pretty subspecialized different populations, so we like to kind of stick to what we know best and provide that transition. And so just a couple more things. Most of us in the epilepsy world will have at least 2 board certifications. Often people will have 3, and will often have multiple degrees. So it's quite a long road. Another question that I sometimes get is 1 or 2 year fellowship. Is 2 years better? Should you see a doctor with 2 years of epilepsy training? Is that better than a doctor with 1 year? The answer is not really, not necessarily. And I'll show you some data to support that. So EEG interpretation accuracy, which is one of the big markers of epilepsy training, doesn't really differ between EEG readers with 1 or 2 years of fellowship training. So the main reason some doctors choose to do an extra year of training is to pursue research or gain further expertise in a specific area. So it's not necessarily that they're becoming, better clinicians, or they're becoming a better epileptologist for you specifically. They might just be kind of pursuing a subset of interests. And then the other thing I'll say is that hospital volume matters. So no matter where doctors do their training, the most important thing is just seeing patients and reading EEG. So the more volume, the better. And why is fellowship training important? So I've alluded to some of this a little bit earlier, but number one, I would say, is accurate EEG interpretation. So, EEG, I think many of you know, is kind of the bread and butter testing that we do in epilepsy. It's what often makes a diagnosis of epilepsy or supports a diagnosis of epilepsy. And it's a very important test that we rely heavily on. So of course, having an accurate EEG read is paramount to good patient care. So here is a study that looked at the accuracy of EEG interpretation among EEG readers and divided into different subpopulations. And so the outcome here is the Breyer score, and a lower Breyer score actually means better accuracy. So the shorter bars in this bar graph actually indicate higher accuracy, so keep that in mind. And so the biggest takeaway from this study is that it seems that board certification and academic practice setting are the biggest predictors of accurate EEG interpretation. So as you can see here in the left-hand column, when you compare academic and private practice doctors, the academic doctors had better EEG interpretation. And then in these two columns, in the third and fourth columns here, you can see that ABCN certification and ABPNE certification, and these are the two board exams for neurophysiology and epilepsy. If you are board certified in these areas, you are much more likely to have an accurate EEG interpretation. So the difference between the blue and green bars is quite sizable. Interestingly, the number of years of fellowship training really did not matter. So as you can see, the bars are overlapping here, the confidence interval bars meaning. So there's really not a significant difference between doctors who did less than 1.5 and more than 1.5 years of epilepsy training. As long as there was some epilepsy fellowship training, their EEG accuracy was pretty consistent. And here's another study from a different group from 2022, which looked at something similar. They wanted to compare EEG accuracy between experts, experienced non-experts, and novices. So experts are the blue dots here in this diagram, and they are defined as having completed at least 1 year of fellowship training in EEG reading. And the way to look at this graph is that the closer you are to this upper left-hand corner here, the more accurate your diagnosis is. So basically, if you're all the way up here, it means you're always right and you're never wrong 100% of the time. And so the original 8 are sort of the gold standard, the EEGers who developed this study and developed the EEGs and the accurate reads themselves. The experts are in blue here, and so as you can see, they come the closest to this upper left-hand corner. So they have the highest rate of detecting true abnormalities, but also the lowest false positive rates. And you can see that the novices in red here are really kind of far over to the right, meaning their false positive rate is high and their sensitivity for detecting true abnormalities is lower. So certainly you would want to have your EEG read by somebody with fellowship training. Another reason fellowship training is important is making an accurate diagnosis. So what is and isn't a seizure? So there's been several studies that looked at this question as well. And the ILAE, or the International League Against Epilepsy, has this stage diagnosis of functional seizures, where some of you may be familiar with the diagnosis or the concept of functional seizures. They're also called non-epileptic seizures, psychogenic non-epileptic seizures, and they can be very difficult to distinguish from epileptic seizures. However, their treatment approach is very different, and so it's really critical to make this diagnosis accurately. And what you see here in this study is that when you involve a seizure physician in making this diagnosis, and that meaning somebody with fellowship training in epilepsy or neurophysiology, your accuracy in making this diagnosis goes up to 90 or 99%, depending on some of what other supportive evidence or studies you have. So again, you're going from a level of 70 to 90% and above just with that additional training. So this is really, really critical. Here's another very big study that was published in JAMA Neurology about 5 years ago now from Dr. Tatum's group that showed when you compare the accuracy of epileptologists and senior neurology residents, basically they showed these doctors videos of seizure-like events and asked them, is this more likely epileptic or non-epileptic? The fellowship-trained doctors were much more accurate than the senior neurology residents in their diagnosis. So again, this extra training is really important because of the extra experience and number of cases we see. And this is kind of saying the same thing in a different way a third time, but when you look, another group looked at the same question in 2017 and looked at the diagnosis of epilepsy by provider type. And what you can see here is that epileptologists had the highest accuracy, followed by general neurologists, and actually neurology nurses, who had an accuracy of 70%, which is quite high when you compare to, for example, internal medicine physicians, emergency physicians, and emergency nurses. So again, these IM physicians, ER physicians, ER nurses, these are often the frontline doctors who might end up making the diagnosis or telling a patient what they do or don't have. And so it's important to remember that studies show that they may only be 50% accurate for some of these cases. So always important to seek out a specialist. Another important reason for fellowship training and for seeking care at an epilepsy center, I would say, is the expertise in anti-seizure medication management. So here's a slide updated through 2021. So there, a newer diagram will be coming out soon of all the different seizure medications that we have and have had on the market. So this is a very long list. There's multiple dozens of medicines on here. And in our epilepsy fellowship training, we get familiar and comfortable with most of these medications. So that means knowing the side effects, knowing what the contraindications are, what we can and can't control with these medicines, when to stop them, what should we monitor when patients are taking them, what's the dosing, what are the formulations, are they available as a liquid, does the liquid taste bad, for our pediatric patients. These are all things that we just become very familiar with. And more than just the medication itself is the logistics around prescribing the medicine and knowing how to manage controlled substances and the difficulty with having them delivered and all these different things. So we just, again, become familiar with that, and we can anticipate some of the challenges and help our patients guide through that, how to write the prescription correctly, minor things like that seem like they should be easy enough to do, but that are really tricky for a lot of general neurologists because there's so many other things that they're doing and thinking about. Whereas we have the luxury of really focusing on this one diagnosis and this one set of medications. Bridging pediatric and adult worlds. So I talked about that already. Basically, because both pediatric and adult epileptologists have that cross training, we're able to talk to each other and understand each other's patient populations and help make that transition as seamless as possible. Of course, it is always inevitably going to be challenging. I think our approach is just as people with a pediatric background versus an adult background, the culture is a little bit different, but we do our best to try to bridge that gap. And then I'll talk more now about learning these higher level skills, so the surgical epilepsy evaluation. So some of you may know that epilepsy surgery is a very complicated process, and it's a very long road to get there. So in order to determine if someone is a candidate for epilepsy surgery and which modality might be best for them, there's a very long kind of set of tests that usually get done. Video EEG, we have 3 Tesla MRI, functional MRI, PET scans, MEG scans, SPECT scans, neuropsych testing, we do intracranial EEG, et cetera, et cetera. So all of these different tests, come with their own risks and benefits. They carry different weight. There's certain things they can and cannot tell us. There's ways that they're reliable and ways that they're not. And all of interpreting these tests and really understanding how to use them is a lot of what our fellowship training is about. And so you really want somebody with that extra in-depth knowledge making decisions for your epilepsy care and understanding what these different tests mean. Word about neuromodulation for seizure prevention. So like I mentioned, non-medical treatment options for epilepsy are a big part of what we do at epilepsy centers. And within that bucket is neuromodulation. So these are electric devices that are implanted within and around the brain to deliver electrical stimulation to different parts of the brain to try to control, reduce and stop seizures. And we currently have 3 devices on the market: the VNS, the RNS, and the DBS systems. And knowing which patients are good candidates for which ones, how the different systems will affect your lifestyle, and how to manage the devices after they're implanted. So programming them, changing the settings, etc. All of that is something we do in our epilepsy fellowship as well. And then lastly, over our training, we become familiar with resources for patients and just getting understanding and a deeper dive into our patients' lives of what it looks like to actually live with this condition and what are the things that make it a little bit easier. And so again, it's just a matter of seeing more people, meeting more people, seeing more clinical scenarios. All of this is what makes us kind of feel more confident in our recommendations. So that's about all I have. So I, like Andrea said, I work with the Northeast Regional Epilepsy Group. We have offices in Morristown, Hackensack, Livingston, and Manhattan. I've provided the phone number here for our Morristown office. And one of our level 3 centers, I should have actually had a picture of it on a map here, but is the RWJ Barnabas network, the Cooperman Barnabas Medical Center. So we have both a pediatric and an adult comprehensive epilepsy center there. And then we also have centers at Overlook Hospital in Summit, as well as Hackensack. So yeah, we're in a lot of different places in the area. So please go to our website and feel free to reach out if you have any questions. So I'll I guess pass the torch back to Andrea to see if there have been any questions or if anyone would like to share any comments.
Thank you so much, Dr. Alexieva. So Dr. Alexieva will leave this slide on the screen, so feel free to jot down her information as she's answering some questions for us today. This webinar was super informative, and I don't think there's enough talking about the differences between an epilepsy center versus a general neurologist that is in town, right? So you said a couple of things that were super interesting to me. One thing, and I'd love for you to chat about it a little bit more. You said that in epilepsy centers, there's often are there monthly meetings or so where you have case studies where you talk about a patient and get referrals and some recommendations on what other doctors would be doing?
Yes, so we typically have weekly or bi-weekly conferences for patients who are interested in pursuing epilepsy surgery, where we review their seizures, their neuropsychological data, their MRI, all the data we have on them. And basically it's really wonderful. You have the attention of 5 or 6 different doctors who are all listening to the case and saying, hey, have you thought about this? I think this test would be really helpful. Or have you tried this medication? I had a similar patient who really benefited. So we exchange ideas. We also decide usually it's with the goal of deciding what the best surgical management is, because again, these cases are very high level and complicated. So we always want to have as many different experts weighing in as possible.
That's great. So in addition to all those extra services like a dietitian or a neuropsychologist, I think it's wonderful that in an epilepsy center, all the doctors can kind of get together and chat about a specific patient in a case study. I think it's also interesting that, and I think it's wonderful that oftentimes, so many people are controlled with medication, and they think that that's wonderful to be controlled on medication, but side effects can be really tough. So I think it's really interesting that you said if there's side effects, you should be going to an epilepsy center to be evaluated by an epileptologist and talk about some changes that can be made to your medication.
Absolutely. And we always say that our goal is no seizures, no side effects. That's always what we're aiming for. So if there are intolerable side effects, we don't feel like we're done.
That's great. That's great. And another thing that I jotted down a bunch. I learned a lot, Dr. Alexieva. I've been in this role for a while, so it's great to always learn. And you also said it's okay to get a second opinion at another epilepsy center. The doctor's not going to be insulted. It's your life. It's your diagnosis.
Absolutely, 100%. I would say if it were my friend or family member, I would always encourage getting a second opinion. Oftentimes, even when they say the exact same thing, that just gives you more confidence.
I agree. Okay, so one question was to me, yes, this webinar will be recorded. You'll be receiving an email with a link to the recording as well as it being on our website.
All right.
Okay. So somebody did ask, and I think you already answered it. So there's this one individual, and I'm not going to get into specifics. If you have specific questions, I can definitely pose them to Dr. Alexieva in an email. But one attendee has been going to an epilepsy center for the past 10 years, and they like to seek other opinions. So they're currently taking 2 epilepsy medications. So as you mentioned, there's so many different epilepsy centers in New Jersey. We're very fortunate. You don't have to go into, you can go to New York or Philadelphia, but there are options in New Jersey. And as Dr. Alexieva shared, it's definitely worth it to get that second opinion if you need more assistance and you're not getting the answers that you want at the epilepsy center that you're at. Again, if you have any questions, please type them into the section of your toolbar. I'm sorry, I'm just reading some of the questions that are coming in. Dr. Alexieva, we're getting great feedback. Thank you, great information. So I just want to make sure that I'm sharing that all with you as well.
Great, I'm glad. Hopefully it was helpful. And if anyone has specific feedback on what you'd like to hear more of next time, I'm happy to give this talk again in the future on a recurring basis. And then any questions, please reach out.
That's wonderful. Yes, and to us as well. So if you did hear anything that Dr. Alexieva spoke about today, definitely let Epilepsy Services of New Jersey know, and we'll plan another webinar on a specific topic that seems to interest all the attendees. But this was super informative, Dr. Alexieva. We really appreciate you taking time out of your busy schedule to present this today. Wonderful information, and just remember, it's your health, and you want to get the best care for it and the most comprehensive care. So it was nice learning more about what Epilepsy Center Level 3 and 4 are. So thank you so much, Dr. Alexieva.
It's my pleasure. Thank you for having me.
Have a great day, everybody.
Take care. Bye-bye.